Rheumatoid arthritis is a systemic autoimmune disease. What that means is it can affect all parts of the body. It's usually bilaterally symmetrical, which means it's on both sides of the body. It doesn't have to be the exact same joints. Usually there is an hour of morning stiffness or more. So it's a disease that causes you to feel sick and achy and stiff. Why we call it a systemic autoimmune disease is because it can affect all parts of your body. It can affect your skin, it can affect your heart and your lungs and your eyes. And so it's not just in the joints, but because almost everybody with rheumatoid arthritis has joint pain, that's the way that it is described. Rheumatoid arthritis is a disease that affects all age groups. It affects more than 300,000 children in the United States of America. Oftentimes it is between the third and sixth decade of life. It's a little bit more equal after the menopause, but before the menopause it's 2 to 3 times more likely in women than it is in men. Rheumatoid arthritis statistically can decrease your longevity by 10 to 15 years if it goes untreated. And so rheumatoid arthritis actually does have a bearing on how long you live. Nobody ever writes on a death certificate that the cause of death is rheumatoid arthritis. However, it also is a risk factor in heart disease. And of course, we know the #1 killer of men and women is heart disease. Nobody really knows what causes rheumatoid arthritis. There are leaders in the field of rheumatology who are convinced. One might say it's a retrovirus, and the other might say it's a mycobacterium. In fact, we don't know what causes rheumatoid arthritis. Certainly there is some trigger because everybody who comes to see me says, I was well until I got sick. So there's something that started that. And because it's an autoimmune disease, it frequently has a genetic component. So in other words, a mother or a grandmother or an aunt might have had rheumatoid arthritis, but somewhere in there, there's a trigger as well. Everybody's disease is different because patients are like snowflakes, they're no two alike. However, the greater the inflammation, the more your chance of destruction and crippling of the disease. New medicines were developed that really changed the landscape of rheumatology. Because some of the medicines that we had been using, for instance, methotrexate, which is a chemotherapy, when you add on the newer medicines, biologic response modifiers, you can decrease the chance of erosion or destruction of the joint to about 1 or 2%. So the newer medicines have really been a huge breakthrough, which have kept rheumatoid arthritis in the year 2000 to be not such a crippling disease. I think the questions that are reasonable to ask him are, looking at me and comparing me to your other patients, how would you say I stack up? Do I have mild, moderate, or severe rheumatoid arthritis? And why? Is my prognosis good or guarded or bad? And I think in general, rheumatologists are not going to say to a patient with rheumatoid arthritis that they have a dismal prognosis, but they may say, you have a very high blood test, your rheumatoid factor is high, your sedimentation rate is high, and so because of that, your prognosis is worse. And so we have to give you stronger medicines. So that is often the conversation that you would have with the patient.